research networks for this survey. So, as many of you know, children with medical complexity, or CMC, are characterized by their severe chronic medical conditions that are associated with functional limitations, as well as high healthcare utilization. And although they represent a small portion of the pediatric population, they account for a disproportionate share of hospital use. And for CMC, the hospital to home transition is a particularly vulnerable period. At discharge, responsibility for managing complex care shifts from the inpatient team to family caregivers who now need to coordinate medications, equipment, follow-up care, and monitoring all at home. And many interventions that are designed to improve hospital to home transitions have focused primarily on preparing families before hospital discharge. So examples include standardized discharge checklist, pharmacy-led medication reviews, and ensuring that families leave the hospital with medications and equipment in hand. However, families often continue to experience challenges once they return home. This suggests that efforts focused on the pre-discharge period may not quite be sufficient, and that additional support extending into the post-discharge period may be needed. So our study was aimed to characterize current post-discharge interventions for CMC across children's hospitals in the US and Canada. And we were trying to use this finding to inform prioritization of interventions using a feasibility and impact matrix. We conducted a cross-sectional survey of pediatric hospitalist site representatives between January to February 2025 through two PHM research networks in North America, one being PIRN, representing 26 Canadian sites at the time, and the PRISE network, pediatric research in inpatient setting, representing 98 US sites. We developed the survey using a structured survey development process, which I'll go through quickly. First, we conducted a literature review of interventions designed to support hospital to home transitions for CMC. From this, we identified 10 post-discharge interventions of interest. For this study, we defined post-discharge interventions as supports that either occur before discharge or provide information or guidance to families that they can refer to after returning home. The interventions ranged from low resource approach, like written discharge instructions that's tailored to the family, to higher resource approach, like post-discharge home visits. And the survey then underwent multiple rounds of pre-testing with hospitalists, subspecialists, social workers, and parents to ensure that the questions were clear and the contents were valid. The final survey contained 19 items where respondents rated the frequency of use of each intervention at the hospital, its perceived impact and feasibility, and ranked their top 5 interventions. The survey invitations were sent electronically using RedCap to one site lead at each hospital, and the goal was to obtain a single response per site. The site leads could either complete the survey themselves or forward it to a colleague who may be more familiar with the care of CMC at the hospital. And additionally, we obtained data on hospital characteristics from the annual site survey for PRISE sites and through additional survey items for PERN sites. We used descriptive statistics to summarize hospital characteristics, and Canadian hospitals that were members of both PERN and PRISE were classified as PERN sites only for the purpose of this analysis. And to examine intervention use across sites, we created a cluster heat map showing the frequency of use of each intervention. Respondents also rated perceived impact and feasibility, which we then plotted on a feasibility impact matrix. And finally, respondents ranked their top 5 interventions by perceived impact, which we applied BORDA scoring, assigning 5 points to rank 1, through 1 point to rank 5, and sum these scores across the respondents to identify the highest ranking interventions. So moving on to some results. In total, 77 sites completed the survey, corresponding to an overall response rate of 62%, and we were able to exceed our target rate of 60%. The response rates were higher among PIRN sites. Thank you so much for completing this, at 81% compared to 57% among PRICE sites. On the map on the right, it shows the geographic distribution of responding hospital sites. Each blue dot represents a site, and as you can see, responding sites were distributed across all regions of the US and Canada. This table summarizes characteristics of responding sites. Overall, the majority of the sites were freestanding children's hospitals located in urban areas. And in general, US sites tended to be larger, while Canadian sites included more smaller children's hospital. When we asked hospitals whether they had dedicated services for CMC, we found that in the US, 41% of responding sites reported having none, whereas most Canadian sites reported having at least an outpatient CMC programs. We found that relatively few sites in either country had both inpatient and outpatient services that are specific to CMC. Overall, we found that the use of post-discharge supports was limited. Across sites, hospitals reported using a mean of 2.1 out of 10 listed interventions, most or all the time. And sites that had both inpatient and outpatient CMC programs reported using more interventions on average, 3 compared to 1.7 interventions at sites with no CMC services, which was statistically significant. This heat map shows the frequency of use of each intervention across responding sites. Here, each row represents a hospital and each column represents an intervention. And darker blue indicates more consistent use. First, we noticed in general that there was substantial variation across hospitals, with some sites, those at the bottom, using several interventions consistently, while others, those at the top, using very few. Second, we found that less resource-intensive interventions, such as written discharge instructions or written contingency plans that are tailored to the patient, were more frequently used, whereas more resource-intensive interventions, such as post-discharge home visits or telemedicine visits, were used less often. Respondents also rated the perceived impact and feasibility of each intervention. And here, each panel represents one intervention, and each point represents a respondent's rating. I know it's a little busy, but the x-axis represents perceived feasibility, moving lower to higher from left to right, and the y-axis represents perceived impact, moving from lower to higher impact from bottom to top. And I'd like to point out 3 general patterns that we observed from this matrix. First, a group of interventions were rated as highly feasible, although their perceived impact was variable. These included written discharge instructions and contingency plans. Second, a group of interventions had more variable ratings of both feasibility and impact, including post-discharge phone calls and verbal communication between inpatient team and primary care pediatrician. And finally, a third group of interventions were rated as less feasible, even though their perceived impact varied. These included post-discharge telemedicine visits, pre-discharge huddle meeting with PCP and inpatient team, and post-discharge home visits. And lastly, we asked respondents to rank their top five interventions by perceived impact. The highest ranked intervention was providing families with written contingency plans that outline steps that parents should take if issues arise at home. And this was closely followed by tailored written discharge instructions and a designated single point of contact for post-discharge questions. I know I've given a lot of results, but taken together, here are 4 key findings that we'd like to share from our study. First, the use of post-discharge supports for CMC varies widely across hospitals. And we found that hospitals reported using relatively few of these 10 interventions that were mentioned in the literature, either through clinical trials or qualitative studies. On average, sites reported using 2.1 out of 10 most or all the time. Third, lower resource interventions tended to be used more frequently than more resource intensive approaches. And finally, when respondents ranked interventions by perceived impact, the highest ranked approaches focused on providing more clear guidance for caregivers after discharge. And of course, there are several limitations of the study to consider. First, the responses reflect the perspectives of site representatives, and they may not capture all practice within the hospital that they're representing. Secondly, our measures of intervention use, impact, and feasibility were all self-reported and may be subject to reporting bias. Third, the study was conducted within the PRISE and PIRN research network sites, so findings may not be generalizable to other hospitals. And finally, we assessed perceived impact and feasibility rather than measuring the true impact and effects of these interventions on patient outcomes. And with these results, we are extending this work in several directions. First, we're currently analyzing a similar survey that we conducted last year with non-hospitalist stakeholders, including subspecialists, primary care providers, and social workers to understand their perspectives. And more importantly, we will be surveying families of CMC to hear their perspectives. The survey is currently undergoing translation into multiple languages, and several PERN site leads have kindly agreed last year at the time of initial survey to distribute the survey through their family advisory councils. So some of you may be seeing an email about this in the next few months. And finally, this work is informing the development of family-centered post-discharge interventions that we're planning to design so that it's usable, acceptable, and feasible to implement in real-world inpatient settings. In conclusion, post-discharge supports for CMC are used inconsistently across the hospitals in the US and Canada, and relatively few interventions are implemented routinely. Second, hospitalist site representatives identified several interventions that were perceived to be both feasible and impactful. And finally, these findings can help us inform development and implementation of some of these interventions so that we can improve the transitions from hospital to home for CMC. I'd like to acknowledge my mentors and collaborators for the study, as well as the PERN and PRISE research networks and the site representatives who participate in the survey. The survey would not have been possible without the support from PERN, so thank you so much. Here are my references, and I'd be happy to take some questions.